You know that feeling, right? When your body just suddenly throws something completely unexpected at you,
Hmm.
like a weird pain maybe, that pops up out of nowhere and makes you just stop and go, whoa, what's that?
Yeah, absolutely. Happens to everyone.
Well, today we're doing a deep dive into one of those exact things, a real potential troublemaker, acute appendicitis.
Ah, yes. The infamous appy.
Exactly. It's something, most of us probably don't give a second thought to until it decides to make itself known loudly.
That's right. And we've been looking through some pretty detailed medical guidelines on it, sort of the roadmap for how doctors understand and handle it.
Right.
And what really stands out is how fast things can escalate from what seems minor to something really quite serious.
Okay, so what's our mission for this deep dive then?
Our goal is really to give you, the listener, a clear picture. What kicks off appendicitis, how can you spot the signs, and, what happens medically.
Kind of the essential briefing on it.
Exactly. Clear, memorable, hopefully useful.
Okay, let's start at square one. The appendix itself.
Yeah.
It's just this tiny little organ, isn't it? Feels almost like an afterthought.
It does seem that way sometimes, like a little pouch attached to the large intestine. But yeah, as our sources show, it can cause some major issues.
So what actually starts the problem? What leads to appendicitis?
Well, the number one cause, most commonly, is a blockage. Think of it like a pipe getting clogged.
Okay.
In the appendix, this is often caused by something called a fecalith, basically a small, hard piece of stool that gets stuck in the opening.
A fecalith. Okay.
Yeah, and once it's lodged there and maybe calcifies a bit, they might call it an appendiculate. Same idea, though it's blocking the exit.
Is that the only thing that can block it?
No, not always. The guidelines mention other possibilities, too, like maybe a foreign object someone swallowed, though that's less common.
Right.
Or sometimes the lymphatic tissue in the appendix wall can swell up and cause a blockage that's called lymphoid hyperplasia. And even things like tumors can do it, but that's rarer.
So basically something gets stuck. Then what happens? I'm guessing it's not just uncomfortable.
No, definitely not. Once that opening is blocked, the bacteria that normally live quite happily inside the appendix get trapped. And they start to multiply. It's like sealing a container with something organic inside. Things grow.
Right, right.
So you get inflammation setting, the bacteria count goes way up. That's the bacterial overgrowth. And all this creates pressure inside the appendix. It starts to swell.
Okay.
One source kind of described it like an overfilled balloon. But, instead of air, it's full of infected material. Kind of icky stuff.
Yikes. An overfilled balloon of Bic. That sounds bad. What's the danger if it keeps swelling?
The big worry is perforation.
Meaning it bursts.
Exactly.
Yeah.
The balloon pops. If that inflamed appendix wall ruptures, all those bacteria and that infected fluid spill out into the abdominal cavity.
Oh, wow.
That causes something called peritonitis, inflammation of the peritoneum, which is the lining of the abdomen. And that's a really serious, potentially life-threatening infection. It spreads fast.
Okay, so cause, blockage, danger, bursting, and peritonitis.
Got it.
Yeah.
So how would someone, know they might have this? What are the telltale signs?
Well, there's what doctors call the classic presentation, and that really centers on pain in the lower right part of the abdomen, the right lower quadrant, or RLQ.
RLQ pain. Okay.
But what's interesting and kind of classic is how the pain starts. Often, it doesn't begin in the RLQ. It frequently starts as this dull ache right around the belly button.
Around the navel.
Yeah, periumbilical pain is the term. And then usually over a period of a few hours, that pain tends to shift or migrate down and to the right, becoming sharper and more localized in that RLQ area.
Huh. That's specific. Is that the McBurney's point thing I've heard about?
You got it. McBurney's point is a specific spot roughly 2/3 of the way from the belly button to the hip bone on the right side. If a doctor presses gently there and it's really tender, that's a big sign.
Okay.
And they'll also check for something called rebound tenderness.
Rebound. What's that? It's where they press down on the abdomen, maybe not even right on McBurney's point, and then quickly let go. If the pain is actually worse when they release the pressure, that rebound pain is another strong indicator of inflammation irritating that peritoneal lining.
Gotcha. So pain that moves, specific tender spot, pain when you let go. What else? Any other symptoms that usually come along with it?
Yes, definitely.
Yeah.
A very common one is loss of appetite, just not feeling hungry at all. Often goes hand in hand with nausea and sometimes vomiting too.
Right. The guidelines mention that's important for parents, right?
Yeah, absolutely. Because a kid might just say their tummy hurts, but if they also have zero interest in food, maybe feel sick. That combination should raise a red flag beyond just a simple stomach bug.
Makes sense. But you mentioned it's not always that classic picture. The notes talked about atypical symptoms. Why is it important to know about those?
It's really crucial because if you only look for the classic signs, you could miss it in some people. Appendicitis can definitely present differently.
Like who?
Well, very young children, for example, they might not be able to say, my pain moved from here to here. They might just be, generally unwell, fussy, maybe have a slight fever, seem lethargic.
Harder to pin down.
Exactly. And then elderly individuals, their symptoms can sometimes be much milder or more vague. Maybe they downplay the pain or it gets mistaken for something else, like constipation or another issue.
Okay.
And another key group is pregnant women. As the baby grows, the uterus pushes the appendix upwards and sometimes outwards.
Ah, so the pain wouldn't be in the usual RLQ spot.
It might not be. It could be higher up or more towards the flank, or even feel like gallbladder pain sometimes. So recognizing these variations is vital to avoid a delayed diagnosis, which can be dangerous.
That really highlights the need for doctors to think broadly. Okay, so someone comes in, maybe with classic symptoms, maybe atypical ones. What happens next? How do they confirm it?
The first thing is always gathering information.
Hmm.
The history. When did the pain start? What does it feel like?
Hmm.
Sharp, dull. Where is it exactly? Did it move?
All those details we just talked about.
Precisely. Plus asking about the other stuff, nausea, vomiting, appetite, any fever. Then comes the physical exam.
Gently poking the tummy.
Basically, yeah.
Yeah.
Gentle palpation of the abdomen, feeling for tenderness, especially in that RLQ. Looking for that rebound tenderness we mentioned, maybe checking for muscle guarding, where the abdominal muscles tense up instinctively.
Okay, history and physical exam. Then labs, I assume. Blood tests.
Yep. Standard procedure. They'll draw blood to check the white blood cell count, the WBC. An elevated WBC count often signals infection or inflammation somewhere in the body.
But not just appendicitis, right?
Oh, exactly. It's
Yeah.
an indicator, but not definitive on its own. Other things can raise the WBC count. They'll also usually get a urine sample,
Why urine?
mostly to rule out other possibilities like a urinary tract infection, UTI, or maybe kidney stones, because the pain from those can sometimes mimic appendicitis symptoms. A clean urine sample makes those less likely.
So the labs have narrowed it down, but they don't give the final answer.
Not usually on their own. They add pieces to the puzzle, but imaging is typically needed for a more confident diagnosis.
Right, seeing is believing. What kind of imaging?
The gold standard, as they often call it, is a CT scan of the abdomen and pelvis.
CT scan.
Okay, it's very good at visualizing the appendix itself. Doctors can see if it looks swollen, inflamed, if the wall is thickened. They can also see complications, like if it has actually perforated or if there's free fluid or an abscess forming nearby.
So it gives a pretty clear picture.
It does. But CT scans involve radiation. So especially in children and in pregnant women, they often prefer to start with an ultrasound.
Ultrasound first.
Yeah, particularly in those groups, to avoid the radiation dose. Ultrasound can often visualize an inflamed appendix too, especially in kids who tend to have less abdominal fat obscuring the view. It might not be quite as definitive as CT for seeing complications sometimes, but it's a very valuable first step.
Okay, so history, exam, labs, imaging. Let's say the diagnosis is confirmed, it's appendicitis. What's the immediate plan in the ER?
All right, so once they're pretty sure it's AIppy, the focus shifts to getting the patient stable and comfortable, relatively speaking.
Pain management?
Absolutely key. As the guidelines stress, the pain can be really intense, especially if there's already perforation. So they'll start an IV line right away.
For fluids?
Yes, partly for hydration, because nausea and vomiting can lead to dehydration, but also as a route to give medications. They'll typically give intravenous pain relief, often narcotics, to get the pain under control.
Makes sense.
And anti-nausea medication too, if that's an issue. And one really crucial thing, the patient will be made NPO.
NPO.
Nothing by mouth. No food, no drink.
Ah, because surgery might be needed.
Exactly. It's standard preparation in case they need to go to the operating room quickly.
Which leads us to the main fix, right? Getting the appendix out.
That's the definitive treatment, yes. A surgeon needs to be consulted promptly to assess the patient and decide if an appendectomy surgical removal of the appendix is the right course, which it usually is.
Are there different ways they do the surgery?
Yep, two main approaches. There's the traditional open appendectomy, which involves a slightly larger incision in the RLQ,
Okay.
or, increasingly common now, is the laparoscopic appendectomy. That's minimally invasive. They make a few tiny incisions and use a camera and special instruments to remove the appendix.
Less invasive, probably faster recovery.
Generally, yes. But the choice depends on the situation, the surgeon's preference, and sometimes how complex the case is, like if there's already a rupture.
And the main goal is to do this before it bursts, ideally.
That's always the ideal scenario. Get it out while it's just inflamed, before perforation and peritonitis set in.
But what if that icky balloon has already burst? What happens then? Is surgery still the answer?
Yes, surgery is still usually needed, but the situation is definitely more serious if perforation has occurred.
How so?
Well, there's a much higher risk of the patient becoming really unwell, potentially developing sepsis.
Sepsis, that's the body's overwhelming response to infection, right?
Exactly. It can be life-threatening. The abdominal pain is usually much more severe and widespread. The abdomen might become rigid to the touch. And there's a risk of forming an abscess, a walled-off pocket of pus, which might need draining separately.
So much more complicated.
Definitely more complicated, requires more intensive treatment, often longer hospital stays, maybe stronger antibiotics. But the bottom line, perforated or not, is that quick action is essential.
Okay. So surgery's done, appendix is out. What's the focus then during recovery? What are they keeping an eye on?
Pain control remains important, of course, making sure the patient is comfortable.
Right.
Close monitoring of vital signs is crucial: heart rate, blood pressure, breathing, and especially temperature. Checking for any fever that might indicate a persistent or new infection.
Makes sense. Watching for problems.
Yep. And keeping an eye on those lab results, like the white blood cell count, to see if it's coming back down to normal. Any significant changes get reported right away.
What about educating the patient?
Oh, absolutely vital. Explaining why the surgery happened, what they can expect during recovery activity levels, wound care, signs of infection to watch for at home.
And explaining any tests they had.
Yeah, if they had a CT or ultrasound, just making sure they understand what was done. It's all about keeping them informed and ensuring careful, proactive care. No surprises, if possible. Constant vigilance.
Okay, that was a really thorough deep dive. Let's try and boil it down. What are the absolute key takeaways for you, the listener, about appendicitis?
Let's say number one, the cause is usually a blockage. Simple concept, big consequences.
Right, blockage.
Number two, the symptoms. Know the classic signs that migrating pain starting near the belly button, moving to the RLQ, loss of appetite, nausea. But also remember, it can look different, especially in kids, the elderly, and pregnant women.
Classic and atypical symptoms. Got it.
Three, diagnosis relies on the whole picture: the story, the exam, labs, and crucially, imaging like CT or ultrasound.
History, exam, labs, imaging.
And four, the treatment is usually surgery, an appendectomy, and the goal is to do it quickly, ideally before it ruptures.
Blockage, symptoms, diagnosis, surgery, and speed.
Yes, that speed factor is huge. How quickly it can go from, my tummy feels a bit off, to a major medical emergency. It really drives home why you shouldn't ignore persistent or worsening abdominal pain.
Absolutely. That rapid escalation is maybe the most striking part. It really fits that idea of the appendix being this quiet thing until it suddenly, well, explodes onto the scene.
Perfectly put. Unsung hero, or maybe unsung potential villain until it acts up.
So maybe a final thought for you to take away. As you go about your day, perhaps just spare a thought for all the bits and pieces inside you that are working away quietly. It's kind of amazing, isn't it, how intricate our bodies are, and how something seemingly small, like the appendix, can have such a big impact when things go wrong. It makes you appreciate the importance of listening to your body, noticing those early warning signs.
Definitely makes you think about what other little parts are just doing their job day in, day out that we never consider until we have to. A good reminder to appreciate the complexity.